Good morning, ladies and gentlemen, dear colleagues. It's a pleasure and honor to be with you again here at the new edition of Advances in Surgery channel. My name is Peter Kronenberg. I'm a consultant urological surgeon at Hospital Descobertas in Lisbon. Today, we will talk about the new and innovative Thulium fiber laser technology and how it can be used to treat non-muscle invasive bladder cancer, benign prostatic hyperplasia, and kidney stones. Together with me is an excellent faculty composed by key opinion leaders in these fields. We have Dr. Guido Kamphuis, which is the world-renowned endourologist who works at the AMC, the Academic Medical Center of the University of Amsterdam in the Netherlands. We also have Professor Bjerggaard, Professor and Chairman of the Nordic Urological Cancer Group and Chief of Operations of BlackRest, the Bladder Cancer Research Team at Aarhus University Hospital in Denmark. And also Professor Felix Chun, who is the Chairman of the Department of Urology at the University Hospital in Frankfurt in Germany. So I will now give a brief introduction about this new and fascinating technology. So these are my disclosures. And well, holmium laser lithotripsy has been around for the last 30 years. And we urologists, we like the holmium laser so much because it's absorbed by water after 0.4 millimeters, making it a very safe laser to use. It fragments and ablates any type of stone, and it cuts, coagulates, and ablates and enucleates tissues, making it the safest, most useful, and versatile and successful of all lasers in urology, and it truly deserves to be called the gold standard. However, now, besides holmium, you have thulium. That's why you have the thulium fiber laser. But what are the differences between these lasers? So, if you want to build a holmium yak laser, what do we need? We need a flash lamp, a laser rod or amplifying medium, and this flash lamp pumps photons into this amplifying medium. And at the sides, we have laser mirrors where these photons reflect and they produce laser radiation according to the material inside of the laser rod. And to make everything more efficient, everything is wrapped with a reflective cavity. And this is called a resonance chamber. So, as you can see, the flash lamp and the laser rod, they occupy a very small space of the laser lithotripsy. Most of the space is occupied by the cooling system. And of course, these systems are normally restricted to 30 watts or 25 hertz. If you want to use more power or frequency, well, then you have to use more resonance chambers. And let's not forget the big cooling system that you need to cool these systems down. In comparison, a thulium fiber laser, well, you just need some electronically controlled laser diodes, and then you use a laser fiber as an amplifying medium. So inside the machine, you have a very big laser fiber. That's why the name, it's a thulium fiber laser, because it's a fiber that produces the laser beam. And then you can connect almost a patient laser fiber directly to the system. And the system is so small and so compact that a simple fan is enough to cool the whole system down. But okay. But when we compare the wavelengths of these pulse lasers, they are quite similar. But when we take a closer look, we see that the holmium yak laser and the thulium fiber laser, in comparison to each other, the thulium fiber laser is 4 times more absorbed by water than the holmium yak. So, what is the meaning of this? How does it translate itself in surgical outcomes? Well, when we compare the speed concerning fragmentation of stones, the thulium fiber laser fragments twice as fast as holmium yak lasers. And concerning dusting, the thulium fiber laser is able to dust 4 times faster than the holmium yak laser. Of course, these are all bench tests in the laboratory. But still, the thulium fiber laser allows much faster ablation for any setting and for any type of stone. And even retropulsion, which is so annoying with the Thulium laser, well, it also occurs with the Thulium fiber laser, but sometimes it's so small that it's sometimes even inexistent. Even at very high pulse energies, there is 3 times less retropulsion. And of course, the Thulium fiber laser is also useful for soft tissue applications. When even this 30-year-old paper, which compared different wavelengths and their effect on human tissues, we see that to have the same effect on tissues, we need 4 times less energy. Even on other type of tissues, and also the collateral thermal damage, when we use a certain amount of energy, there's 4 times less collateral damage to the surrounding tissues when we use the Thulium fiber laser. And when we compare the beam profile of both lasers, well, the Thulium laser produces a scattered beam profile, while in comparison, the Thulium fiber laser produces a very focused and concentrated beam profile. And the effect on soft tissues, it's clearly visible on histological sections. The Thulium laser produces irregular incision zones and deeper coagulation zones, while the Thulium fiber laser, well, it produces a very precise incision and a clearly defined coagulation zone. But what about machine specifications about this new technology? Well, we know that Thulium lasers, they are able to produce 0.2 joules up to 6 joules, while in comparison, the Thulium fiber lasers, such as the SOLTIVE, it produces exactly the same settings, but also additional millijoule settings, which are so important for dusting of stones. And the frequency, well, Thulium lasers, especially the high power ones, can go up to 100 Hertz, but the Thulium fiber laser can go up to over 2,000 watts. So just imagine the opportunities that this technology might offer for us and the urologists. And also the pulse duration, which is also very important. We have short, medium, and long pulse durations with the Thulium laser. But with the Thulium fiber laser, we can do exactly the same and go over it with significant longer pulse durations, up to 40 times longer. So we see that high power EX, high power Thulium lasers, they allow us to have a very big range of settings. With the Thulium fiber laser, we have a even bigger different parameter combinations available for us to choose from. And concerning the machines, well, Thulium lasers, they are heavy machines. One of the latest models goes over 300 kilograms. And in comparison, a Thulium fiber laser, well, it's a small machine. It's only 35 kilograms. So besides being much smaller and much lighter, it's also outperforming the Thulium laser. And as we've seen before, our operating rooms, they are already crammed with lots of materials, and having a high-power Thulium laser won't make it even spacier. So with a Thulium fiber laser, because it's so small, it can even fit in the shelf in the endoscopy cart shelf. So there is no need to drag this laser around. It's already there when you need it. And the energy consumption is also quite different. Thulium laser, they are power-hungry machines, up to 10,000 watts, while the Thulium fiber laser only uses 800 to 1,000 watts. And if you consider the hairdryer that you have at home, well, a simple hairdryer consumes twice as much energy than you would need to power up such a Thulium fiber laser machine. And of course, this has a very important implication, because you have to have a special plug to have these Thulium lasers working inside your operating room. So you need a special electrical installation in your OR. While the Thulium fiber laser, well, since it consumes the power it consumes is very low, every standard power plug is enough to have it working and running. So there is no need for a special electrical installation in your operating room. So if you still remember why the endourologists like the Thulium laser so much, well, here are the reasons why we will love the Thulium fiber laser even more. Because it's absorbed by water after 0.1 millimeter, making it an even safer laser machine. It has much more laser setting combinations to choose from, and it's able to fragment and ablate any type of stone as well as any tissue more efficiently than the holmium yak laser. And all of this comes in a smaller package, less cumbersome, more energy efficient, and less power hungry and quiet, requiring low maintenance. So it has all the criteria to become the safest, most useful, and versatile of all lasers in urology. So, and having said that, let's now go to our wonderful panelists who will talk about the clinical efficiency and outcomes of using this new technology.
Hello everybody, this is the presentation SOLTIVE, Thulium fiber laser for stone treatment. My name is Kamphuis, I'm a urologist at the Amsterdam University Medical Clinic. So, you've just heard the story about the technique of the Thulium fiber laser, but I want to start with the holmium laser, because for the last decades we have been working in stone treatment with holmium laser with great results. So what you see here on the left hand side is the start of a ureteroscopic treatment of a big cystine stone. What you can see, the laser fiber on the side of the screen, you can slowly start with just dusting the stone perfectly. And on the right hand side, what you just saw, and I'm gonna start again, no. What you see here is the dusting of a calcium phosphate, calcium oxalate dihydrate stone, and also those stones were perfectly dustable with the right settings with a holmium laser, either low or high power. But then what we have been doing is also treating calcium oxalate monohydrate stones, and it ends up a lot of times, like I'm showing here on the left hand side, with breaking the stone into pieces and having to take them out piece by piece. And if it's a big stone, that takes and can take a lot of time. And also, the sound is still on. Also here what you see is treating a bigger stone. This is a calcium oxalate dihydrate, monohydrate and phosphate stone combined. If you are treating a big stone, it might end up with popcorning or pop dusting, bigger fragments at the end. And sometimes the image gets blurry and it's difficult to assess if you have treated all the stones. So, and here you see a recent review. We were happy with the holmium laser, but there are some technical difficulties and limitations with regard to the stones that we can try to treat ureteroscopically. And like Peter has just told you, there's a different player on the market with the thulium fiber, and the big difference is the absorption. And the absorption by water is higher, and that's why we expect it and also see that there's a different treatment effect of this laser on stones. Another paper, this one by Peter, showing the results recently published in March, the results of a systematic review, and 60 papers are included showing the advantages of thulium fiber laser over holmium yak laser. We have been working with the thulium fiber laser now for the last year, and this is the setup like we use it in the OR. And what we have been seeing and what has been promoted in the papers, but also in real life, our experience is that there's almost no retropulsion, that you can do very fine dusting in any kind of stone, that is relatively fast, and there's an enormous range of settings. Besides that, it's a versatile laser, so you can also use it for the treatment of upper tract urothelial cancer, BPH or bladder abnormalities. What you can see here, I'll show the CT scan, is a patient with a longer existing obstructing proximal ureter stone, a patient with some difficulty expressing herself, so she has been suffering from that from a long time. And what you can see in this video is that there is a fully impacted proximal ureter stone. There's a lot of edema around it, and you can see on the lower video that we're starting laser treatment of this stone. And in the next videos, what you see here is the impact of the stone and also the effect of the treatment, but also the fact that you hardly see any retropulsion by treating it locally, so you don't have to chase up fragments. The other thing is that you can very finely distinguish the area that you can make an impact on the tissue. If you treat a stone that's so impacted, it's not, or almost in my hands, not possible to not leave any marks, but you can see here that you can minimize that effect with using this laser and the high absorption. There's also some downsides in the treatment with the Thulium fiber laser. There's an enormous range of settings, so there's a chance of getting excited, getting bold. You have to be aware that you can also heat and damage tissue. The effects of the laser on stones are different than we're used with holmium. There's some burning effect and flashes, and on the video you see some burning effect there. It looks like it made a dice. Sometimes retropulsion is also something that we use in clinical situations that can benefit us, and if it's absent, you have to compensate for that. We can use with the Thulium fiber laser very thin fiber, but it's also more fragile, so you have to be aware. So you have to adjust your technique and the usage of the laser. So I want to show you here a case of a patient who's known with stones, a recurrent stone former. She's known with a tight ureter, been described before as whitish, narrow, and she is known with the discomfort of a double J, and she's saying, well, I really would not like that. And what you see here on the CT scan, she has pain complaints, sometimes some colicky, macroscopic hematuria, and there's a serious stone of 17 by 16 by 14 millimeters, 991 Hound field units. So what we've discussed with this patient is that we would go in, we treat her ureteroscopically. We are already aware that there might be a problem with the ureter, making it difficult to place an access sheet. So you don't want to go in and out multiple times to take out fragments. We also want to do a stone analysis, so you want to get out a piece for stone analysis. And she doesn't want to be pre-stented, and if possible not post-stented. I think a lot of patients ask that question. So what you see here is the start. You see irrigation fluid, you see a clear stone, a guide wire next to the scope. There's a nice stone in the renal pelvis. And here you see the start of the dusting setting. We have used a 200 Hertz and a 0.1 Joule short pulse. I think it comes into the image. And we start by tasting the stone, seeing the effect of the lithotripsy on the stone. You can see here that the stone is has a nice form. Of course, it will break into some pieces of this formation. It's not a solid rock stone. But what you can see here is you can try to taste the stone, try to see how the effect is in this setting with 0.1 Joule, 200 Hertz and a short pulse. The movements of the kidney are with the respiration and also the heartbeat, so you can adjust a little bit for that. Make sure that you keep your foot on the pedal, keep on slowly progressing, try not to make any holes in the kidney stone, avoid making lesions on the urothelium. And what you see here with this effect is that you can very nicely break the stone into really small pieces and dust the stone. So during a lithotripsy, I like to start with a low setting and then adjust according to the effect. What you saw there is the breaking of a small piece. Even though you're working with such low energy, stones can still break. We will find a piece like that and break it further. What you see here is at the end effect of fragments. We're going to take some out for stone analysis. So the biggest one, the biggest fragments that eventually did break off, we have chased it, fragmented further. You can nicely relate the size to the size of the guide wire to see if there's any fragments that are big. Normally I don't like to leave anything bigger than 1 millimeter inside the kidney. Here you see the effect of the irrigation on the dust and small fragments. And by using that, the image is still clear, as you can see. You can go around the kidney looking for any fragments that are bigger to treat them or take them out and at least leave 1 or 2 bigger pieces. This procedure, the laser time in the procedure was 20 minutes 20 seconds. We used 24 kilojoules. So the stone fragment was sent for analysis. We left the WJ for a couple of days, took it out I think 4 or 5 days later. We left no bladder catheter, and a CT scan 6 weeks later shows no residual fragments. Thank you for your attention. Happy to discuss any questions.
Thank you very much for the invitation of giving this lecture on treatment of small bladder tumors in the outpatient setting during flexible cystoscopy. My name is Bjerggaard. I'm professor in urology, located here in Aarhus at Aarhus University Hospital. These are my disclosures. This is a hospital. As you can see, it's very well located close to the sea, and I'm right now here at my office at the penthouse. Treatment of bladder tumors is standardly done by resection through a TURBT. This is done to remove the tumors, and it's a treatment of the non-muscle invasive tumors. But it's also very vital for a good pathology report to see which kind of tumor you're dealing with. This is mostly important for first-time tumors. So if all first-time TURBTs could be done by a dedicated specialist, this would be optimal. Whereas if you look at recurrent tumors, it's another situation, because most recurrent tumors are exactly the same pathology as the first tumor. So if you have a TA low-grade tumor the first time, the probability of having a TA low-grade tumor at the second resection is close to 100%. Therefore, it's not that essential to have the right histology at recurrent tumors. Another problem in bladder cancer is the high recurrence rate, as you can see from this randomized trial on photodynamics. Irrespectively of whether you used PDD or not during your flexible cystoscopies, the recurrence rate was close to 50% within a year. So it's a very big problem. When the patient comes for a flexible cystoscopy in follow-up like this, you look up in the bladder and, oh, there it was, another tumor. And this tumor is slightly too big to just fulgurate, because if you have very small tumors, as recurrences usually are, you can fulgurate them. But in this case, where it's 5 to 7 millimeters, it's slightly too big just to fulgurate simply. You end up in problems trying to do that, at least. So usually the patient instead goes for repeated TURBT. However, there is always a risk associated here, and you can see these pictures I've stole from the internet. Fortunately, it was not myself, of course, but it could have been that. A hole in the bladder, and that's not a good thing. Even though it's a TA low-grade tumor, the patients suffer from this complication. Another thing is, if you're going through repeated resection, it's mostly investigated in TUR of the prostate, but also in bladder cancer patients, where I found that hospitalization for these repeated resections have an impact on the quality of life. So it makes a difference for the patient and the symptoms afterwards, having a resectoscope up through your urethra. If you look at the size of the urethra and the size of the resectoscope, you definitely want to have that up there as few times as possible. But on the other hand, if you can fulgurate through the outpatient clinic, it's very nicely investigated in Sweden here that the patients would prefer that, and 99% of the patients undergoing cystoscopy, and even the patients which were submitted to biopsy and fulguration in the outpatient clinic, 93% of these would prefer that as a repeated procedure instead of undergoing general anesthesia. The outpatient fulguration history at our institution starts with this. We still have this, actually. We have invested in a slightly newer instrument some years ago, but it's basically the same technology where you go up and fulgurate in the bladder with a simple fulguration electrode. But recently, we've started investigating instead using the laser for these outpatient fulguration. That increases the number of patients you can treat significantly. Here we have a video. As you can see, it's slightly bigger tumor than what you would normally fulgurate in the outpatient clinic. This particular patient was a first-time tumor but had severe comorbidity, so we decided to laser treat him. We did a preoperative or pre-treatment biopsy. Of course, we cannot see whether there's invasion based on this biopsy. As you can see, it's slightly superficial. But anyway, we got the grading, which was low grade. So from that perspective, whether the patient had superficial invasion in the middle of that tumor didn't make a difference for this particular patient. So we started doing the coagulation for hemostasis here with the hemostasis mode of the laser, as you can see. Another very good thing about this is it's very flexible. This tumor was actually very close to the bladder neck, so this flexible approach instead of having to resect the prostate was very favorable. And as you can see, you can easily then disintegrate the tumor or have it evaporated with the laser. This is done through a flexible cystoscope, and at this point we had no irrigation, but of course we have saline attached so we can do irrigation. We also have the suction device for this, because you have some air development, and especially if it's a tumor in the upper part of the bladder, it's essential to have that air sucked out before doing the evaporation. But as you can see here, we can very elegantly go down through the tumor and also do some slightly heavy coagulation on the tumor stalk here. So this tumor, which was 1 to 1.5 centimeters, and this first-time tumor, very comorbid patient, was treated efficiently. And as you can see here, this is a picture of the tumor site 3 months later. It looks almost identical to when you've done a transurethral resection through conventional TURBT. Whether it goes as deep in the detrusor muscle, we still do not know. Here's another example. It was a recurrent tumor. As you can see here, you have some slight tumor tissue here, even more visible in NBI. And the patient also had a small additional tumor at the other location here. So again, we take the biopsy just to ensure that this patient with a history of TA low grade still has low grade disease. Come in with the laser and do first for hemostasis. As you can see here, you have to do the hemostasis first, or else your vision will be lost. But it's very efficient to do that. These patients had no general anesthesia, and this was painless, as we had installed lidocaine 2%, 60 milliliters in the bladder 1 hour before the procedure. So they underwent flexible procedure to see that there was a tumor there, and if it was a very small tumor, we'll just fulgurate it. But these slightly larger tumor areas, and if you have multiple tumor areas, we offer the patient the opportunity of have this installation, which we urge them to take, and we do the installation through the flexible cystoscope, let them wait for 1 hour, and then you can do the fulguration and do that more efficiently than if you had not put in the installation lidocaine. So again, the tumor area is very efficiently coagulated here, and of course we also coagulated the additional small tumors. If you want to install mitomycin after the procedure, you can easily do this, as the risk of perforation, as you can see here, is very, very low. And again here, the tumor area 3.5 months later in this patient. So what we're aiming at is doing the once-in-a-lifetime TURBT strategy, where we aim at no TURBTs and general anesthesia for recurrent bladder cancer. In this way, we can prioritize the surgical time at the OR for first-time tumors and have them done by dedicated urologists and not residents that coincidentally are running around doing multiple TURBTs. This strategy is based on, in many patients with multiple small recurrences, we use chemoresection, but in those 50% of the patients that do not respond to chemoresection, or if they have slightly larger tumor, well, there we have the laser for treatment in the outpatient clinic, leaving us with no patients coming for TURBT for recurrent tumor at the OR in very near future. This is our research unit at the University Hospital here in Aarhus. You're welcome to come and visit us here, and I'll be happy to take any questions. Thank you.
Dear colleagues, warm welcome from Frankfurt, Germany. My name is Felix Chun. I'm the head of the Department of Urology at the University Hospital here. The title of our talk today is Treatment of BPH, and I would like to introduce to you the new SOLTIVE laser system and the SOLTIVE laser enucleation of the prostate. These are my personal disclosures. And that's the overview of my talk today. I would like to give you an idea of the therapy landscape for BPO in Germany. Then what do the guidelines say? What are the surgical principles? What's the evidence of the SOLTIVE procedure? And my take-homes for you. Well, this slide should just let you understand that the enucleation, the holmium laser enucleation of the prostate only represents 6% of all surgical procedures for BPO in Germany in the year 2006. So, in contradistinction, the guidelines, EAU, AUA, NICE, or even the German guidelines, of course, they all recommend the endoscopic enucleation of the prostate as the golden standard, the new standard, versus the formerly gold standard of TURP or open prostatectomy, due to maximal tissue ablation, size independency, superior urodynamic bladder outlet desobstruction, and excellent long-term outcome, as well as producing a complete histology. So this is level 1 evidence and a grade A recommendation. What is the surgical principle? Well, it's been lent from the HOLEP procedure, which you may all know, and you can do it in 1, 2, or 3 lobe technique. And yes, we have also posted a video for our resident society, and you can find it there. So basically,
the question is, we perform with the SOLTIVE procedure the identical outside-in surgical technique as with HOLEP, and does that produce identical outcomes? What's the evidence? Well, this is a group of Moscow. Inikeev Dmitry is the lead author and the lead PI in this group, and basically what they did is in this paper that they showed that SOLAP versus HOLEP, in this case it's feasible and safe, and it has similar tissue ablation rates and functional outcome. Then we have a comparison between open prostatectomy versus SOLAP. And yes, what we can see for SOLAP holds true versus open prostatectomy: shorter catheter time, shorter length of stay, fewer transfusion rates for the SOLAP procedure. Another one, looking at the functional outcome, in this case the erectile function versus TURP. And here also it's been shown that the SOLAP versus TURP produces superior erectile functional outcome in this study. So what is the SOLAP potential? We have a very new technique in our hands, and in terms of sphincter preparation, we can adapt to lower energy cutting. We have an advantage, and I will show you after the slide presentation in my video, that you have clear incision lines. The question that's been going to be raised is it also superior in functional outcome? But from the physical aspect here, we can talk and coin it as precision laser surgery. In terms of bleeding complications, we see a potential in a faster procedure. We have a steeper learning curve. We have less blood loss, and we still need to show that this translates into less complications and potentially also shorter length of stay. And even ambulatory procedure may be the question. So do we have on the patient-related profile side superior outcomes as well? And then we also see, in comparison to the well-established golden standard of the holmium laser enucleation of the prostate, that we have a potential and improvement of the so-called water cushion or peak power effect compared to the holmium laser. Certainly we need to look at midterm multi-institutional results, and yes, what we eventually will need are prospective head-to-head comparisons to demonstrate a non-inferiority to established EEPs, for example, HOLEP. My take-homes for you. Well, in Germany, TURP still dominates the surgical BPS landscape. The endoscopic laser enucleation is the golden standard, and these criteria are being fulfilled by the SOLAP procedure. The first clinical evidence that we have in our hands demonstrates that SOLAP is comparable to HOLEP. The SOLAP potential follows the motto: maximize the benefit, minimize the harm. And what we do need in the future are multi-institutional prospective head-to-head evidence. And yes, I'm happy to share with you that we do have a multi-institutional initiative underway. We would like to at least build up a clinical registry, and these are some of the protagonists that will contribute to this clinical registry. So thank you very much for your attention, and I hope you will enjoy our upcoming video, which comes now. Thank you very much. We've prepared for you are two prostates, one 70-gram prostate and one of 160 gram, and both are being operated in the two-lobe technique. Here we go. These are our settings, and this is work in progress actually. It's on the left pedal, the energy by 1.5 and the frequency of 40, and on the coagulation pedal we have 0.3 and 60. Adding up to 18 watts and 60 watts respectively. And this is these are the settings that we're needing, but we are still indeed are trying also to experience the variability of the new SOLTIVE laser, and are changing it constantly. What are the steps of the procedure? Well, omega-shaped incision for the access. We do then a midline incision, and then we develop the regularly the left lateral lobe. We do an early sphincter release. We cut the commissure on 12 o'clock. Then the bladder neck follows. Then we do the coagulation part and the morcellation. And to understand better, you do the identical procedures on the right and on the left lateral lobe. We always take the left lobe first, and then the middle lobe and the right lobe in one piece. So it's a two-lobe technique. Here you see the 70-gram prostate, the orifices and the bladder. And the access is via an omega-shaped incision line, and you can see it in a moment. Here we start. And what's so nice, by doing this omega-shaped incision, you almost immediately find the right plane. You have some calculi sometimes, and that is a good sign, because that tells you that you're in the correct plane. Then we do a 5 or 7 o'clock incision, depending on the technique. In this case, we do a 6 o'clock incision, because we do not have a middle lobe. We start preparing the left lateral lobe. And you see the vision is perfect. The bleeding is minimal. And even for colleagues that are very well trained with HoLab, the optical quality is amazing. Here we perform the early release of the sphincter. We prepare in a retrograde fashion, coming from the apex towards the bladder neck. We prepare the apical part of the adenoma, then develop it further on the lateral side. Then we mobilize it beyond 12 o'clock from the left lateral side. Then we cut the commissure, and the sphincter has been early released, so it's far away from the incision lines. And retrogradely we take down the left lateral lobe, and there you see some mini bleedings, and you also see the effect on the tissue. It does coagulate a little bit more compared to a holmium laser, but you see the immediate effect. Then we prepare the mid and right lateral lobe. Of course, you always have to watch out and take care in terms of the ureteral orifices. But due to the perfect absorption in water, the surgeon actually feels pretty safe, even if the orifices are closed, like in this case. As a contradistinction to the Holmium procedure, I think surgeons need to be aware of the fact that you need to use your enucleoscope a little bit more compared to the Holmium procedure. So you need to have this gentle pressure on the lobe you are preparing, and you see it also, I believe, very clearly in this video, I hope. And then we did the identical technique on the right lateral lobe. This is the 160 gram prostate. Again, omega incision around the vero. Midline incision in this case as well. Development of the apical cheeks, of the adenoma, and the early turning of the instruments really helps to stay in the anatomical plane and stay in the right plane where you need to go from outside to inside. Early sphincter release. It's not bleeding at all, and it's really very good vision. That is being produced by the Thulium fiber laser, by the SOLTIVE system. And in this case, in larger prostates, you enter the bladder actually on a 1 o'clock position, between 1 and 2 o'clock to enter the bladder, and then you do a descending technique in larger prostates like here. And it's important to not lose your plane. Now at 12 o'clock we cut the commissure again. Go back to the bladder neck, complete the enucleation. Here you see a little laceration of the capsula. Move on to the mid and right lateral lobe. Use your scope gently. Turn it early, especially in larger prostates. That's a good piece of advice. Sphincter release. And staying on the plane, and because your vision is so good, it's always a simultaneous playing. Here you see a bleeder. That's interesting. You see the whitening and the carbonization of the tissue, and the bleeding stops. Here again. And here are some of our tricks. So be gentle with the prostate. Think of early turning of the instrument. Do an early sphincter release to avoid tension on the sphincter. Entering the commissure apically in larger glands, and precise coagulation before morcellation is key. Then morcellation should not be problem, and what we still recommend is to incise the adenoma before morcellation for better grip for the morcellator. So I hope you liked the presentation, and I'm open and ready for discussion. Thank you very much.
Okay, after having had this wonderful talks, let's start with our questions. So, first questions for Dr. Kamphuis. How do you select your settings when approaching a new stone for the first time?
Hi, Peter. I think that's an excellent question. It's always important to evaluate the situation. So the location where you are you in the ureter? Are you in the kidney itself? Is it a wide system? Is it closed? What's the pressure? Do you have an access sheet? Do you have a good flow? Was it already difficult to get a scope up? And what's the goal? You want to break it, you want to dust it, you are able to take out fragments, or is it a really big stone that you have to dust? Then you evaluate the stone type, you have an idea what kind of stone it is. And then normally what I do, I start low. So I start with 0.05 to 0.1 joule and 100 to 200 hertz, and then look at the effect. I use a short pulse and kind of taste the stone, see the effect, and then I evaluate and adjust depending on the effect of the laser on the stone.
Okay, thank you for your answer. Now, Professor Bjerggaard, which settings are you using during your outpatient laser ablation of non-muscle invasive bladder cancer?
Well, first of all, we use the 200 micron fiber instead of the smaller one, because it's easier to operate through the flexible scope with a slightly thicker laser fiber. For the ablation, we go as low as we can with watts, so only 5 watt. That's 0.5 joules with 10 hertz. That's what we have aimed at, to have it as safe as possible. For the hemostasis, it's slightly higher, so it's 0.6 joules, 30 hertz, equaling 18 watts.
Okay, thank you. So, and Professor Chun, which settings do you use, and do they remain the same overall, the surgery, like you explained, or do you sometimes change your settings during the enucleation?
Thank you very much for the question, Peter. Well, to answer you is, I think we all have to keep in mind that we are dealing with a novel technology and new ranges that we can use, and it's still work in progress in terms of enucleation of the prostate. Currently, for the enucleation part, we're using 1.5 joules and 40 hertz, so adding up to 60 watts. We're using a medium pulse length. And for coagulation, we are using 0.3 joules, 60 hertz, and summing up to 18 watts, and a long pulse. We have changed it. We are using it ever since autumn last year. And I will not exclude that we are maybe have new settings in the future. During the procedure itself, we have played around a little bit in terms of the early sphincter release to lower the energy. And but actually what we found out is that it is so precise also in terms of the sphincter region that we are using for the enucleation part the same settings now.
Okay, well, I understand it's a new technology, so there are new data coming in and we are learning over the way. So since it's a new technology, Dr. Kamphuis, what is the biggest advantage of using Thulium fiber lasers compared to the older technology of holmium yak lasers?
Well, Peter, I think it's the versatility of the laser. So you have a really wide range of settings, and you can adjust the laser to the goal that you want to achieve, and you're not limited with the technique instead of older, mainly lower power holmium lasers. With the higher power holmium lasers, you already have a wider range of settings. And then also the secondary items of the thulium fiber laser come into play, like the size of the machine, the normal power socket, the noise that it makes. It's all favorable to this machine. So those for me are really advantages in daily practice.
Okay, thank you. So back to you, Professor Bjerggaard. So what are the main differences and advantages of this technique and technology in comparison to the classical monopolar or bipolar TURB?
Well, the biggest difference is that obviously, like shown in the videos, you could do this as an outpatient procedure where the patient is not under general anesthesia, which has some logistic advantages, some economic advantages, but also some very good advantages for the patients after the procedure. They only have the flexible cystoscope there. And as we can do it rather painless here with rather big tumors, I think the only thing we are a bit going down on is the histology here. But as we prefer to do it in comorbid patients, but also in patients with recurrent GA low grade, where we take a biopsy to see if it's still low grade. I think it's very safe. So I think it's kind of a revolution going from a lot of procedures in the OR in general anesthesia with the rigid scope and to this. And obviously, if you have larger tumors at the bladder neck where you can almost only see them if you loop the scope, you can still do this with this laser fiber. Whereas in patients with big prostates, you have to resect part of the prostate to go for traditional TURB. So that's an additional great advantage for the surgeon and for the patient.
I see. But would you consider, for example, using this technology for en bloc resection of smaller tumors?
Well, you can do it. I would not. I prefer doing the ablation. When we're doing TURBTs, we started doing en bloc. But doing it for these typically low-grade tumors where you can safely coagulate it or ablate it from the top, I would go for that because it's more painless to do it like that when you only hit the top of the tumor instead of going down into the bladder. That's more difficult to do with anesthesia. Then you have to put in some local anesthesia with a needle. So for the outpatient procedures, I would prefer just pure ablation.
Okay, I understand. Okay, thank you so much. Professor Chun, so do you see, after having seen the numbers that you have presented, do you see that endoscopic enucleation will be the way to treat BPH in the future?
Good question, Peter. Thank you. Well, I believe that the field of urology is a very innovative field, and we are also technically driven, certainly. But we also, at the same time, we are also traditionalists, saying that I believe that TURP remains with us as a surgical procedure. It will, certainly, but according to the level of evidence and the grade A recommendation, I also believe that in the future, endoscopic enucleation will certainly increase with the younger generations. In the end, certainly, we are all clinicians, and if somebody is very good at TURP, I would never argue against it. However, as we are moving forward, we will also embrace novel technologies, and the SOLAB will be hopefully, or we'll see about that in the future, but potentially be also one alternative to the other endoscopic enucleation techniques.
So it comes to the opportunity of being able to learn this new technique.
Certainly, certainly.
Okay. Thank you. So back to you, Dr. Kamphuis. What would you recommend for new users who are starting using this new technology, the thulium fiber laser, with regards on your own learning curve on this new technology?
I think that's a really important question also, Peter. If you have a new machine, you want to try it, but you have to first understand what it does, and be safe. I think if you're working with a high power holmium, if you have experience with that, the step to a thulium fiber laser is a really small one. There are some changes you have to adapt, but the most important thing is if you are used to work with a lower power holmium, be aware that you're using a machine that can generate a lot of more power, and be careful. The learning curve for me personally has been working with the fiber in a good distance from the scope to avoid flashes and burning effect. So the way that you have to keep on moving a little bit, and the distance to the tip of the fiber, those were the things that I had to adjust, and be working in a safe distance to avoid getting overexcited, using too much energy. I think that's the most important points if you start working with this machine.
Okay, thank you for your answer. Professor Bjerggaard, how can this change the way we treat non-muscle invasive bladder cancer, these low-grade cancers? How will it change in the future, and do you foresee any impact on patient outcomes?
Well, as I mentioned in the talk, I hope that we will reserve the TURBTs and the OR for first-time tumors. So more or less have no patients coming for repeated TURBT in the OR. Of course, we still have patients with recurrences irrespectively of instillation therapy, but I think instillation therapy as an chemoablation also has a great role that we'll see in the near future. But it'll not cure all the patients, so we still have some patients with recurrences. And the majority of these, I think they can very safely be treated in the outpatient clinic, with benefit for the patients, but also benefit for the patients coming for first-time recurrent tumors. So we'll have, as I mentioned, dedicated surgeons doing all the procedures. So we'll get the unblocked resection, we'll get the correct specimen, you'll get the correct handling every time, instead of having multiple surgeons involved. And I think dedicated surgeons for primary TURBs is very, very important. TURBT tends to be something you let the residents do on the first day. And of course, if it's a recurrence of small GA low-grade tumors, that might be safe unless they make a hole in the bladder. But in my opinion, that's a totally wrong way to treat the patients, if you can do it like this. So hopefully, as said, we'll take the patients just and do the recurrent ablation in the outpatient clinic. So the patient, they see the tumor, they have it ablated, they go out again, do not have to fear for the next TURBT and the next follow-up. So I hope that's where we're going.
Yeah, but this way of treating this subset of patients, it goes always hand in hand with using mitomycin after the ablation of these small tumors.
Well, if you have a strategy of using single installation afterwards, you can also safely use it here. As you can see, there's no hole in the bladder and so on. You could easily give it. The majority of the patients we've been treating like this, they are set up for adjuvant installation, and if you are going for that anyway, we do not give a single installation here. But of course, if you have a patient where you think you're not going to give adjuvant, you could give installation therapy. We do not know whether it's necessary here, because one of the theories behind the mechanism is when you do the resection, you have the vital tumor tissue laying around there. You'll have the implantation and metastasis. Okay. But here you have only necrotic cells floating after ablation. So maybe it's not necessary to give it. And as said, if we're going for a strategy with more adjuvant installation, we do not give it. So in our setting, we do not use the single installation.
There are still some questions to research for them. Okay.
Yeah, fortunately.
Okay, Professor Chun. So talking about this new technology and how people have to learn about it. So how would you recommend to new users who are starting to use the Thulium fiber laser with regards to your own experience? What would you recommend?
Well, above all, I would recommend that the colleagues who would like to learn it should be experienced in endourology. That's one. Two, and also in the handling of laser technology, certainly. Two, I would tell them that a little bit of patience is necessary. And even, for example, very experienced like therapists may need to address the learning curve. And we know it from HOLAB, about 50 cases is the benchmark to be up and running. And I would not start with too large and not too small prostate sizes. So a size between 50 to 70 grams would be ideal. Then certainly a proctoring system should be, if available, is always helpful. So you can pool on one day 2, 3, 4, 5 patients and then have a proctor helping you. And also use the online video libraries that are available, because certainly these are experts, but it shows you where to go and how to address it. And in the end, of course, you can always salvage it with your conventional TRP, for example, if you're not getting along. And so never lose your nerves, but keep calm and stay with the technology. Simple recommendations like never lose your plane, follow the plane, and that's for sure. And I think that the SOLTIVE system enables you to have, especially in the learning curve, a clearer vision. So it might overcome the long learning curve of HOLAB, maybe a little bit, and that would be nice. Yes.
Okay. So, but since, well, actually with all this pandemic, virtual and online courses have boomed. So, and what do you think? Is there a place for some virtual and online education considering laser enucleation of the prostate, or it's always needed to be like a proctorship or some hands-on experience?
I think it's a combination of both, as said, and of course you can watch beautiful videos like the music video library from the University of Michigan, as we all know, and AIS channel, for example. These are great opportunities to get acquainted with the technique. But if it comes to hands-on, especially in the enucleation part, then it might be of great use to have a proctor and just to get a slight idea of, for example, when to turn the scope, how much pressure can be applied on the lobe you're enucleating, and so forth. And I think that yes, the virtual libraries, video libraries are an add-on to the practical experience.
Okay, well, thank you for your answer. I think that's it. So thank you for this wonderful discussion to all the panelists. And ladies and gentlemen, I hope to see you again here at Advances in Surgery channel. Goodbye.
We are constantly improving our surgical training. This is why we need you to participate in our AIS core initiative to rate the quality of our content. You can rate our content by giving it a score from 0 to 10. 0 meaning not useful and 10 meaning extremely useful. You can tell us if this is a good content to share. Thank you for your commitment to the democratization of surgical training.